Yeah. So we'll just start at the beginning. Just kind of what was your general thoughts on this article? What did you guys think? Feelings after reading it?
I was really happy to see this article because it really got to the point, and I loved its charts. At first I was going 19 pages, but then it's like they really summarized it.
Yeah.
So I liked it.
Anyone else had general thoughts or? So what do you guys think? I kind of made these questions to help guide us. I used the AOTA has a journal club toolkit, so that's where these questions came from. If you're curious, kind of how I came up with those. But so what were the questions you felt like the researchers were trying to answer? What was the point of it?
His role in chronic pain management.
Yeah. I thought on the second page summed it up really well. It's like right before methods. Yeah, the purpose was to present a review and provide an overview of the current knowledge about OT's role, like you said, models, assessments, and intervention methods used for adults living with chronic pain. To me, that was like the, kind of what they were working towards. Great. Methods. Anybody have any thoughts on their methods, or kind of like what methods they used, or felt like it was lacking anywhere?
That again was good.
Mm-hmm. Yeah, I like the flow chart.
Mm-hmm. I think it's something that we could use if we were ever looking for something. We could just go, okay, well, what are we identifying, and what's going on here, and how can we look for information from articles?
Yeah, like if we wanted to know more, that's a good, like this is how they kind of work through it. So that's a good place to start of, okay, well, I needed to know more maybe about this one area or for this one population or something. Limitations. I think with every study, we're gonna always have our limitations. Was there something that they noted in the limitations, or that you also were reading and felt like limited the study? I have an extra one too somewhere, I think, or something to borrow mine if you need it.
I felt like they did a really good job summarizing past research studies, but I'm almost surprised that there aren't more.
Yeah.
This is a meta-analysis.
Mm-hmm. But I'm just surprised there aren't more research done on chronic pain with OT.
I like that when they made the chart of all the research studies that they put what the N was. And I was surprised to see so many with like pretty large numbers. I was expecting to see way more with like 1 or 2 or like a series, and I was surprised to see that they weren't all just that.
Yeah. I also like that it was like, their research wasn't limited to one region or geographical area either. They took research from all over. And I liked the chart that had like where it was from. I think sometimes that changes the perspective of how it was looking and the culture behind it as well.
I commented in the
Oh, I'm sorry.
Go ahead, Becky. Is it Becky?
yeah, or Rebecca.
Oh, that's Rebecca. Everybody's confusing us.
Stan, are you able to read that?
What?
Are you able to?
I can read that. Oh, that.
Can you read the? Can you be our chat reader?
Oh, okay. Starting where?
Right. Yeah. Just
right there. Okay.
They
They mentioned in their limitations that the quality of the publications wasn't necessarily controlled for. I also noted that they didn't provide mean and standard deviation of age of participants.
Yeah. That's very true.
Do you think that's because it wasn't in the study information, or they just excluded it? I don't remember. That was like cited in the article.
Huh.
Like in terms of the chart.
Yeah. I don't know.
I agree that they were all used more quantitative studies rather than RTC. Yeah. But I guess pain is a more subjective matter,
Right.
so that's why they were using more expert opinions or like qualitative studies.
Mhm.
But it's just something we were not too familiar with, I guess. Well, I guess it's something that we were taking that level of evidence. It wasn't on
Mm-hmm.
top of that.
But that said, what I liked is they got specific when they explained how they started off with so many. And like say, I was kind of surprised that they excluded hand therapy. But then I thought to myself, well, they're getting really specific here. And then they winnowed it down to what, 40, 52 out of like, yeah. I mean, it was really, yeah, the flow chart shows you, they started out with 524 and then got it down to 237 and then got it down to 52, you know, and so I liked that because there's so much noise. So I think the studies they finally got were worthy, you know.
I kind of wish they had gone. I love the chart because it's clear, but I felt like then I needed to also go read those articles to really like formulate a treatment plan to apply it.
Yeah.
So it was like, okay, this is great that this is out there, but now I still feel like I got a lot of work to do.
Yeah.
That was my kind of perspective. Like, okay, well, here's where this study is, but now it doesn't tell me as much about the study as I wanted.
But what about the results? I mean, like, what I liked is they kind of got to, like, okay, what
They kind of summarized
yeah,
it.
it's about person, occupation, environment, and then we went back to like the COPM, and there was something else. I thought, well, that's good because these are pretty well known. I was going to ask, are y'all familiar with the COPM? Yeah. So it's pretty good about, like it would say, so what can't you do because of this pain? And say that. And then how satisfied are you with the way you do it? How do you think you do it? So it's got a satisfaction and a performance scale. And I think the COPM is pretty good, but I was going to be interested to ask, because that's what I know, what you guys in the acute setting, what do y'all use for pain assessment? Do you use the COPM?
A referral.
From?
Well, we refer to the chronic pain center here.
Oh.
So like a lot of times you're managing it on your caseload, but then if it's something that's persistently like hindering practice in some way, we will do a referral, and neuropsych is working on it continuously. So honestly, I hate to say that, but like I don't know that I've ever used a pain specific assessment besides like the FLAC or
What's that?
like the
Likert scale, the 0 to 10.
Oh, okay.
Yeah, so we have a verbal and a nonverbal scale for pain. So like the 1 to 10, and then the other one is based on like, do they grimace? Are they withdrawing from pain? So people that are like not as consistent with verbal communication.
Sorry, I can't see that far. Becky had
Oh,
another
yes.
comment.
Rebecca here.
Oh, sorry, Rebecca. It shows up as Becky. That's why I keep calling you that. I apologize.
That might be her nickname. I did not know that. Okay. All right. I wondered how much cultural norms affect the language verbiage based on where the studies were geographically located. In other words, operational definitions of occupational performance versus occupational engagement. Wow, that's deep. That's very deep. Thank you.
Does Becky have audio? Because she can.
She's recovering from the flu.
Oh, okay.
So-
Right.
Culture, okay.
Becky's like furiously typing.
Oh, okay. Wait, so I'm very sniffly. Okay.
I'm sorry, Becky. I'm not a good listener, obviously.
Okay.
Yeah.
Stan, can you read that again? I think I need a second to process that.
Okay. I wondered how much cultural norms affects the language verbiage based on where the studies were geographically located. In other words, operational definitions of occupational performance versus occupational engagement. I'm very sniffly. And yes, Becky is my nickname.
Okay.
Okay, good.
What do you, I guess, like,
I think that's a great point. I mean,
Yeah.
we see that here, like different cultures or people with different types of backgrounds will come in and they'll either under or over report pain. And sometimes they'll be getting dysreflexic for telling us, in which I get that we have spinal cord injury, so they might be getting dysreflexic and not knowing. But sometimes they clearly look like they're in pain, but they're like, oh no, my pains are one. And then you're taking their blood pressure. It's like through the roof.
Well, it's like Dr. Mingo, right? She was talking about older adults and minority older adults and how they have a different idea of what pain is, right? So yeah,
They
that's a
think
good
they
point.
should be living with it.
Yeah,
Cultural
yeah,
norms.
it's a normal fact of life, I guess.
And not to like go too far down the opioid road too, but their experience around that and availability of that and how much that's culturally accepted as well, I think. Because I see in acute care, different populations refusing pain meds versus requesting them, and there's some trends around that.
I was working with somebody at Emory the other weekend who clearly really needed pain meds, but all they would repeat is like that they didn't want to be labeled like the people that they were. They had very low health literacy, but I think because the only thing they saw in the media was that everyone's addicted if they take it, they wouldn't. I'm like, oh, you could really like do something in therapy, not just decline therapy if you took it.
Yeah. I had this like femur fracture, like clearly painful, like day 1 or 2 post-op. I mean, recent surgery, and he like, because of his health literacy was so low, he thought he was going to be charged extra for the pain medication, and so he was refusing because he like couldn't afford it with like his mindset. So it just took some education around like.
I have to ask, is that true though? I mean, I have to ask that.
We're,
Yeah.
we're daily group billing, so it doesn't matter. We get charged by like diagnosis code
Okay.
for comorbidities, and then we get one fee so the patient doesn't get it. But if they're in a day program here or post acute, then yes.
And acute care, yes,
Okay.
especially for someone without insurance.
Yeah. I think that's probably something to really think about as an OT is, okay, when you're writing your note, is that a factor?
Yeah.
Because what I liked about the paper was it was like, okay, OTs are about occupational performance. So, but if you can't get there because they're paying for the reason that they can't afford it, then it's like, ooh, how do you write that in a note?
That's why I think the COPM is one really good thing, because it's kind of the person's perspective and how that changes for that person. Has anyone, I highlighted this because I had never heard of it, the assessment of pain and occupational performance, abbreviated POP. Has anyone ever used that or heard of that?
I came up in a different journal club, but
Okay.
yeah.
I meant to look.
What page is that on?
It is on page 12 at the bottom, like under the chart.
Okay. Anybody online heard of that? Pop.
I haven't heard of it.
Okay.
Nope.
But then again, I was going to say there are so many pain scales out there.
I think that probably would have been a nice thing to do in that table, unless it was there to say what assessment they used. But I was just scanning real quick. I don't remember reading what they used. But now that I'm looking at this, it's like, okay, wait a minute.
Yeah, they broke it down in that other.
There it is on page 12. Sorry.
I do like the fact that they broke it out that way and the treatment types. Whenever I come across studies like this, though, I realize how much like the EMR dictates like what I do on a daily basis, which is so depressing. And which it really shouldn't be the case, because you can still like indicate a outcome measure or whatever type of measure within your doc. But it's just like we get so used to clicking boxes or being expected to use the pre-formatted things.
Yeah, Rebecca actually mentioned that before, like with home health and our documentation system. I know we only have the Parcel Index built in, so if we want to use another assessment, it's like we could document it in there, but it's not built into the EMR. So, Yeah.
And
And then
then-
just the Barthel index, we have the numbers pain scale, and I think that's about it for OT assessments. There's plenty. Like the COPM will actually be really good for home health, I think, if it were like built in. I wish we could have like a subset that we could choose from and just, it would open up.
In the hand therapy thing I work, I don't know whether we have a quick dash form. Yeah, and then they have one of them is pain scale, and then are you able to open a jar? Are you able to do this and that? But if you have a pain, then of course it's gonna be very much impaired. So the scores are low. But then after that, then it's gonna come back. So a lot of times for treatment for pain in that kind of setting is usually just it's just like I don't know, cold, and also like I would do a lot of iontophoresis stuff. So,
To numb the pain more than anything. Is that what you mean, like cold and ion to do that?
yeah,
Okay.
I don't know how you.
Pain science, especially on your hands as a whole, I think it's personally a lot of perception too. That's why stuff like, and a lot of it comes down to education too. I find some patients I can educate something on something in ergonomics or something like that, and just magically like, oh my gosh, I can do this. Sometimes, because I know we see a lot of post-op too, and sometimes simply me just saying like, you can do this now. They do it, they're like, oh, okay, they didn't hurt that bad. So I think that plays into it a lot as well, perception. And then you get into the whole deep end of like when you see some workers' comp cases and some ADA cases. So pain perception definitely, for me, in this last year of practice has kind of changed down to even like how I ask. Like I don't even ask just like, are you in pain now? I try to ask functionally like, what's still difficult for you? Because I found definitely with open-ended questions and stuff like that, like everybody's gonna say I'm a 9 out of 10 pain. This is everything's just not whether if I say, you know, I see your shirt's on today. Did you put your own shirt on? Your hair's in the ponytail. Did you do that? Did you put your deodorant on? Things like that I found have like been able to get down. So that's why I kind of like the quick dash because it does ask kind of specific questions other than just like, does it hurt? But like, what does it hurt while you're doing it? Which is kind of
That's a good point though, about
For
being
me,
an OT and back to the opiate thing.
Mhm.
I mean, how much pain? Oh, well, take this.
Mhm.
You know, if the focus is there, then it gets lost.
I don't want to miss Becky's comment. I think
It would be interesting to survey other healthcare professionals' current state of knowledge regarding OT's role in pain management.
I would think that there's also a lot related to cancer pain, and they didn't really break it down a lot in terms of the different diagnoses in the articles. I mean, there's like chronic low back pain, but you hear so much about pain and pain scales and pain management with cancer patients.
So Helene, do you think, I mean, as we started out when we said, well, they excluded hand therapy, do you think that that's probably why they would have excluded cancer? Because it seems like they kind of guided this review to more like, I guess, OTs and what they just do for chronic pain, or and didn't break it out. I don't know if that's a plus or a minus, or if it would have been just too noisy.
I mean, it could be. I mean, if you think about it with hand therapy, usually that kind of resolves once they have the therapy. I don't know what percentage of people remain with chronic pain after hand interventions.
I'm just curious, like on an outpatient or even home health, are you guys getting like referrals for straight like pain management?
I've had a few. It'll
Okay.
say neck pain, but it might be like she said, an oncologist or refer,
Okay.
and sometimes just a family practice physician. But I've gotten a few just neck pain.
Okay.
Neck pain. So, and at that point, sometimes that can be resolved with strengthening, especially the low back pain. It's usually weak muscle weakness. So once they are no longer sedentary, that helps. And just to add to what you said, sometimes when I do a home health evaluation, I don't even ask about pain. I just want to see if they'll mention it. And at the end, I'll be like, by the way, do you have any pain? Oh yeah, you know. And it's like, well, if it was that bad, I think they would have mentioned it before really engaging. So I try to do that just to kind of see, okay, are you really in pain, or is it just education about symptoms or things like that? So
That limits them, you know, so you give them techniques to get what they need to have done, but, you know.
yeah, and a lot of it, like you said, is ergonomics. Like we had one lady who was using a cane, and so she was leaning to the side of the cane, but we got her on a walker and posture's upright and no longer has back pain. So sometimes it's literally that simple. And she lived in a house full of like family members, but nobody thought, oh, we need to get you on a walker. So it really could be just those simple fixes that really help. It's really nice to see that improvement in quality of life.
I'm curious how much, like, kind of to add on to Kristen and y'all's comments as well, how much the EMR kind of pushes us. Because, like, especially in acute phases, like, I'm expected to document pain at the beginning and end of every one of my sessions. So I, like, first thing walk in, you know, I'm from OT, how's your pain? You know, and it's like we start with that versus, like, seeing how they do functionally.
I had a conversation with someone how like we perpetuate the idea of pain by asking first. It was actually a physical therapist I talked to about it, and she was just like, "Look, I don't even ask anything about pain until the end because sometimes like I'm prompting them to have pain."
Or they're associating us with
Mindset.
Exactly.
Wow.
The previous EMR was actually removed it. They didn't tell us why, but only until progress notes.
So nice.
Like
So
the whole
uh,
opioid
and
thing.
it might be
I
too,
really
yeah.
think that's probably what's happening is that they're needing to do that.
And I'm going to tag
Yeah.
on the flip side. I forgot to say it too. But I'm starting to see a lot of patients too.
Yeah, here we go.
That maybe
Sorry.
No, I guess you can't touch it,
that
Katie.
is
It's not
older and
right.
they
Yeah.
now
Yeah,
have
that's good.
surgeries or have like carpal tunnel and stuff like that, but are refusing to go down this road or taking anything, but they end up scarring down and getting worse and worse and worse, and it kind of this loop. So it is kind of an interesting thing to bring up. It's kind of a difficult conversation to have too.
Let's scroll up.
I think that we have some comments online we'll catch up on.
From Sarah to everyone.
Okay. Yeah, start with Sarah right
Okay,
there.
so this is from Sarah. I really like how the gentleman relates it to performance and not a number. Thank you for sharing those examples. Sometimes people don't know what they are capable of until they try.
Yep.
Okay, and then we're gonna how do we scroll down here? Where's
Two
the thing?
fingers.
Oh, two
Cool.
fingers. This is overly complex. Okay. P.S. For home care home base users, there is a pain management intervention that carries over into routine visits.
We have to click pain management intervention. Yeah, I use it on every patient for every eval. And so it just prompts you every treatment to make sure you address those interventions dealing with pain, which is usually energy conservation, body mechanics.
We're kind of in the
I
intervention
haven't
section.
clicked that yet.
Well, see, do y'all use that though?
Yeah.
So y'all use home care home base?
Yes.
Oh, I thought you guys were using Kaylee. Oh.
Not anymore.
Oh, wow. Well, I've not clicked it before, and my supervisor will be like, you need to click this on every patient. So I'm like, okay. And even if they have no pain, just like that needs to be on every.
I mean, it makes
I'm
sense.
like, okay,
Yeah.
that's true.
And the program's called Home Care Home Base?
Yeah.
Yeah, my tablet's in the car.
I have a lot of opinions about home care.
Okay.
Yeah.
And
And
I'm sure that they shouldn't even say. I think
I wonder if they ask
It's
for
right
a
here.
window to get a baseline of their pain.
Probably
Sure.
so. Yeah, probably so. And it locks into the OASIS document. So I guess that, but once I do that and sync the eval, it's gonna, every routine visit, every visit after that, there will be interventions for pain. Now, you don't have to provide them every visit, but you can certainly, if you did do it.
Reminder.
Yeah. So, but that's cool. I didn't know you guys were on home care.
Oh yeah.
I think it's interesting what you guys are saying you're doing for pain treatment, and it said the most frequently reported interventions was body mechanics as well as posturing, positioning, energy conservation, and joint sparing techniques.
Is that just because we're used to seeing on that checkbox from
Yeah.
looking at the EMR?
And I remember that was actually an MBCOT question. It was all about.
Like that.
The number one cause of lower back pain is muscle weakness. I just remember that because it was just so easy when I was studying. That was 2015.
I think those areas are very specific to occupational therapy too. I mean, as opposed to other disciplines that are going to cover, physical therapy, doing the muscle strengthening and all that. That's like our thing,
Did anybody see the AOTA community post about the Costco connection article? There was a physical therapist who wrote about how they address pain, and they just took all the shine, which was great. It was like, oh gosh, that would have been a good opportunity for OT to really educate on, in a big retailer magazine.
Yes.
Just the Costco. And so I commented back on that thread, just asking how we can be involved, because I think the AOTA social media relations chair was like, we can collaborate to make an article for Costco or just big retailer magazines to educate about what we do. But physical therapy really talked about, they said they do upper body exercise, they help with ADLs. I mean, they took the shine for, which I appreciate, but I'm like, man, it would have been nice to do something like that. They were just, very aggressive about, publicizing themselves.
Assertive, that's a good assertive. But I also think a journal club like this, back to connecting, to put our comments down on the front page of our webpage, because people will look for OT when they're just looking, and if they see something like that, chronic pain, journal club, the points, it's a start.
Putting it on the website?
Yeah.
Yeah, absolutely.
I mean, we're doing all this work. I mean, right?
Right.
Pain that you're never going to recover from. I mean, you definitely have to get adaptive performance techniques to, educate as well, so that they'll be able to engage. So, yeah, that's definitely our.
So online, we have about 3 minutes before our Zoom runs out.
Oh,
So
no.
make sure you put your email in the comments so we can send you the contact hour. Do you guys have any final comments since your time's going to run up?
I don't. I just think this is a fabulous idea, and I'm glad that you guys instituted it. I thought it was a good topic for the first one.
Celine?
Really tried to pick a topic or pick an article that would go across a lot of different settings and really apply to a lot of different people. So that's my goal. Just so you guys are aware kind of what we're hoping for as we're moving forward. And I've emailed different people from schools and I have contacts in the area. We're hoping to have students and practitioners who conduct research also presenting at these meetings. So they would be presenting on the research they're currently doing, and then we would have like an article to support that, maybe a prior publication or something that correlates with that research, so we can get that combination of what's out there plus what's being done. So that's our goal moving forward with the Journal Club.
I'm also happy that there was a Zoom option.
Yay, I'm glad it worked.
Yeah. Dr. Smith, goodbye. I want to ask you, in your textbook, is there any chapters or anything on pain?
Yeah, there's a pain. Yeah, there's a chapter on pain. Yeah, don't ask me what it says specifically because I haven't looked at it in years.
Okay.
Yeah, no, but there's definitely there's a chapter on it.
Okay.
Yeah.
So I was covered it for research. It's not related, and that's why I was
Also, I'm sorry. Also, I was going to say that there's also a chapter on like standards and regulations where they mention that it's a joint mandate that you have to ask about pain and what your response is to the patient's complaint of pain.
Right, but I think the thing that's going to give us the distinct value of OT is, like Kyle said, how we ask it, or when we ask it, like at the end, or tell me about what you can't do and why, or how happy you are. Anybody else on Zoom? Watching the clock.
Thinking about what you were saying with like a Costco article, I feel like so many people can benefit from OT with pain management. In the future, how do we get it out there for more people?
I was thinking about that. I'm thinking manpower. I mean, I'm really kind of, I'm not going to say aggressive, but I love to interact with people. So I'm like, I don't mind just stopping by doctor's offices and I know you guys are busy, but I just want to leave this for you. Or just having conversations with people. And I know there's a conference, it's not an OT conference, it's Academy of Rehabilitation Medicine, ACRM or something. So going to presenting at conferences like that where there will be multiple providers. But I was thinking about that too, like the other way. And I think PT did right to get in the hospital connection. I mean,
Absolutely.
It was nice. And some OTs on the community forum were kind of, I guess, salty. So I'm like, they did it.
They're there.
They did it. So.
It's a big topic right now with I mean, people are trying to find ways to, I mean, there's major funding going into that right now too. I mean, it's just like to offset that, you know, the use and everything to help people work through it with other means. So
I think that
there's a lot of money in that.
we can get there with the trends in elder and geriatric care and just the aging of America. Start talking about that, and pain just kind of goes with it for all those reasons, like the history you were saying, or what people do. So that's an interesting way to do that.
I'm also interested as people or as more OTs are moving into or attempting to move into the primary care settings and getting into doctor's office at the primary care level, how that would affect referrals in general, but for pain management and for everything. Yeah.
In fact, they potentially should mandate that they have to go through these types of screenings prior to being prescribed medication, you know, like things, or have a certain type of medication regime prescribed for what is normal. But then when people start going out of those parameters, start saying, okay, well then we need to implement these measures, and they have to work through that too before they can offset addiction, you know.
Emergent care is
Urgent care.
oh,
Yeah.
Because I'm mainly orthopedic, so.
Yeah, you're right. I mean, everybody's going to urgent care.
So Zoom says they provided us a gift and we're running out of time, but they are not going to close us at 40 minutes. I don't know why. I'll send you guys a bill if it charges me later.
yeah.
It said it's a gift, so we're going to go with it.
Say that. Kyle, just with you and the emergent care, I mean, it's all there in front of us. We just like preventive care. I mean, there you go.
You know what else has been a huge thing I was gonna tell you is my new, like, I've finally seen some, like, on the business side it's happened to Yelp and Google. You'd be surprised how many people walked through my door and it was like, my hand was hurting. I was Googling, what do I need to do for my hand? Got the hand therapy, and they're sitting there reading reviews like, oh, maybe this is like this. Exactly, it's what we all do.
actually what
The same thing, like, I might stub my toe and be like, why does the front of my head hurt? You
I
start
look at
getting
everything.
Googling it, so that's a big thing. So if you're in, whatever setting you're in, like, get your patients to write about.
The article is good, but also since like I feel like everything's just online now, and that's just like such a huge target to like reach people that like that's even a good platform to try to get our name out.
You bring up a good point. Maybe we should get somebody who knows about how people are accessing the media to talk with us. Like not a marketer, but you know what I mean. Somebody who knows how are people using internet or the technology to give us ideas on how to tap that. Anybody know anybody?
My son does that. Yeah, he's good.
Your son does that?
Yeah, Georgia Tech for artificial intelligence and machine learning, so they do all of the algorithms.
A speaker.
Yeah.
There we go.
I'm a girl smart too. If we wanted to.
How to
Well, that'll
educate
get to your
effectively
point.
on social media
Yeah.
as well.
Yeah. Very good.
Yeah, they're SE. I mean, if anyone has a blog, I mean, when you set up your WordPress blog, they tell you about SEOs, like search engine optimization techniques to use when you're even like writing for your blog.
Thank you for telling me that. I obviously don't know.
No, I'm sure putting them on our website. Yeah. And you can use them on YouTube too. You take all the key terms on top of it.
Anything else?
I was gonna ask when we got to the interventions. Does anybody use video modeling?
Yes.
Okay, thank you, because you said something, Kyle. I'm sorry about. I want to see them do it first
yeah.
before I ask. So I
Put them in
just
front of a
wondered.
mirror sometimes.
Yeah, I mean, after you show them the technique or how to change it, do you show them and say, see?
Stay right here.
Yeah.
Or in the
I
clinic.
mean, I use it with fit
Or in the
today,
clinic, I
but
have video it, yeah, and say like, this is the way you should do like this. Or I have people send me a picture of your desk at work, or bring in a picture of your desk at work. Things like that.
Yeah.
That's nice.
trying to break a manual wheelchair user when they're on an inpatient of horrible technique. That's like, if I cannot get someone to like understand what I'm trying to say, it's like I will have them watch a video of one of our volunteers do it with good ergonomics, and then I'll play a video of myself and be like, look at what's happening with your shoulder structure here. Because they're topless usually doing it. They're men.
Okay. Just wondering about that.
Yeah, that wasn't an intervention that was mentioned,
No.
but I do feel like that's something you utilize.
Talk about a research study. Were you going to say something? I'm sorry.
We did a lot of video modeling for behavior shaping.
Yeah.
And it's mainly for autistic
Yes.
behavior
Mhm.
kids.
Mm-hmm.
Also do a lot of social stories.
Mm-hmm.
Not for pain.
No, but that's
Yeah.
one of the good reasons. You see yourself doing something, you know.
I just wonder, like, for children with behavioral problems, they would, how would that, if the pain would be another factor, then that would be a huge deal in terms of treatment and stuff. So
Yeah.
a lot of them are nonverbal, or a lot of them are cerebral palsy, you know, that would be something to think about.
Yeah.
One thing I love too with video modeling and pictures, especially with kiddos like starting to work, when they see pictures of themselves working, they're like, oh my goodness, like it's great. And they respond in a way that is so unique. And I've even had a kiddo like, oh wow, I would love to see myself working. And so to show them that was really powerful. And even with my husband, like a posture, he bought a new beautiful chair to help with posture, but terrible posture. So it's like, okay, look, like, okay, like the chair's not going to fix it. But it was really impressionable for him to see himself with a bad posture. And they have articles in like the Strata magazine talking about posture. Oh, you need good posture. Their shoulders are raised, their elbows are, you know, it's really bad. And so it's like, have you looked at your pictures? Because that's not a good example. I agree. Pictures are powerful.
Well, that was a great discussion. Thank
I
you
think
guys.
so.
This was wonderful.